Hi, I'm Tom Bagwell, and welcome to Hello Health, a partnership with the Ochsner Health System and Humana to bring Ochsner's Hello Health weekly education and information series to you. This week we're discussing memory trouble with neuropsychologist John Sawyer, the co-director of Ochsner's Cognitive Disorders and Brain Health Program. First, some background. Dr. Sawyer graduated from Millsaps College in Jackson, Mississippi. He was awarded his MS from the University of Southern Mississippi and his PhD in psychology from the University of Memphis. He completed his internship at the Memphis VA Medical Center. He concluded his training with a 2-year fellowship in neuropsychology at the Maryland VA Healthcare System. It is our pleasure to welcome board-certified neuropsychologist Robert John Sawyer to Hello Health. Good to have you with us on the program.
Thank you so much.
And we have something in common. We were both born in Gulfport, Mississippi.
That's right. Absolutely.
Yeah.
Seafood fans.
Yeah. What was it that made you first get interested in psychology, and why did you choose the extra 2 years of training to become a neuropsychologist? And what's the difference, if you can explain to us?
Right. So I remember really distinctly working with patients in mostly therapeutic encounters and trying to help them improve depression, anxiety, and other types of disorders. And what I was noticing is I really wanted to understand what was going on in their mind as well, beyond just their symptoms. And so that transitioned me into specializing in neuropsychology. And so what neuropsychologists do is help to twin both our understanding of the brain and human behavior. And in particularly, why do people have certain troubles with their thinking, memory, attention, focus, and then our job is to assess it, figure out how bad it is, if it is bad, and then what may be causing it, and then how do we fix it. I'm
assuming this is one of the reasons you helped create the Cognitive Disorders and Brain Health Program at Ochsner. So what is the program,
right,
and why is it important?
So the program is one of the first of its kind in our region, and what we're doing is we're trying to do two things. So the first is we know that cognitive trouble is becoming an increased public health problem. Most that's because we're getting older and people are living longer, which is a good thing. But as we live longer, our risk for cognitive problems increases. So we need to have an effective place that can assess, diagnose, and treat individuals that have cognitive trouble across their lifespan. And then we also want to not just treat people who have cognitive trouble, we want to aim to address the problem in our stroke belt, in this area of Louisiana, Mississippi, Arkansas, where risks for stroke and other types of vascular problems is really high. So how do we help people and support them in making really good decisions with regard to what they eat, exercise, sleep, stress, those types of things.
Lots of topics to discuss this morning. Let's start with normal aging, right? So here are some of the areas we're going to be covering.
Yeah, absolutely. So what I want us to kind of talk through is what's normal as we get older. And the hat tip is that it's normal to be abnormal. That's not a problem necessarily. And as we get older, it's normal that if we have certain types of issues around kind of word finding, a little bit of memory trouble, but as we get older, some things really stay the same. So our ability to our reading abilities, our language abilities stay the same. Sometimes they even get better depending on what kind of skills we're kind of avocations we have as we get older. Our long-term memories don't change. So many times people will tell me, well, Grandpa really has no trouble remembering what happened from the 30s and 40s, and that's good. That's okay. That's usually not going to decline in the context of a dementia process. Basic aspects of focus and attention typically stay fine as we get older.
What are some of the areas where we're going to decline, and we know that?
Right. So as we get older, it's normal to have some trouble with word finding. Many people will kind of run through the list of all their adult children before they get to the right one, right?
My grandmother would do it all the time.
Right, exactly, and so does my mother-in-law. And it's okay to have a tip on the tongue phenomenon at times where you can't think of the exact word in conversation. At times you might have more trouble multitasking as well as we get older. Those things aren't the consequence of dementia or Alzheimer's disease. It's just the consequence of our brain aging.
And what about the difference between remembering something that happened yesterday and something that happened at Gulfport High School?
That's a great question. So our long-term memory has been repeated to us usually several times, and so it's stored pretty effectively in a different region of the brain. Where Alzheimer's disease develops, that's where our short-term, our new memories are processed, and so that's why forgetting new information is really a more critical problem than for us to assess. We're not really assessing long-term memory.
Would make some sense. That's why I guess when some people meet someone, they'll say their name. They'll try to use their name 3 or 4 times in the conversation. John, that's right, John. That's right, John. I've heard it 5 times. I remember you're John.
Right. Yeah, absolutely.
How does cognition change over a normal lifespan?
Right. So as we once we hit even in our early to mid 30s, where I am at right now, we can have some mild our aging process almost starts at that point. We're not going to notice really any changes up until our mid 60s, and then from our mid 60s and forward, that's when we might start to slow down in terms of our thinking speed. It may take us longer to process visual information or information that's orally communicated to us. Over time, we might have trouble multitasking or doing things really quickly. That oftentimes gets into the issue around driving in older adults and driving. We know, for instance, that like Secret Service agents have an age cutoff and pilots have an age cutoff. And that's because we know that our reaction times and our decision making in really quick, intense moments slows down. And when time is of the essence, that's just happens when we get older. And so that's a good example, I think, of showing that that's a normal thing as we get older.
Let's talk about dementia. Is it becoming a bigger problem? And if so, why is that the case?
So the biggest risk factor for dementia is age. And our populations are living longer, and that's a consequence of better nutrition, better health care. Most societies are more developed and wealthier, so people are living longer, and we're also able to treat or manage diseases longer in people, so they're living well into their 70s and 80s. But what that does, unfortunately, is our brains really weren't designed to live that long, and so what happens then is once we get into our 8th decade of life, about 50% of people have the plaques and tangles already developing in their brain related to Alzheimer's disease. So that really dramatically increases the likelihood that you may start experiencing memory trouble once you hit 85 or so. News
isn't much better in our region, right?
Right.
So was it a bigger problem here? And if so, do we know why?
Part of there probably are 3 key reasons. So the first is that our region has disproportionate problems with engagement in health behaviors, so problems like poor diet, limited exercise, limited literacy about certain health conditions. Another issue is whenever you have less access to health care, you're not going to seek it as much, and then so you won't be as engaged with your doctor. So that's a problem. And then the third piece obviously involves a culture. We have a culture around certain foods and things like that are hard to change, but in terms of something that's positive, we've seen the dial move really significantly with smoking. In the 50s, everyone smoked. In here, we may have been smoking, on camera back in the 50s and 60s, but now no one does that anymore. So it does require a new effort to try to really change the culture, so that way we're prioritizing what we eat and exercise and those types of things.
And the financial cost to this increased dementia is staggering.
It is staggering. It's staggering in terms of the cost of care as we get older, the cost of what nursing homes cost for families. It's also extremely expensive in terms of the psychological cost. I see caregivers who are burnt out, who are stressed, who feel guilty, who are taking time off from work, people who never thought that this is what retirement would look like for them, parents who have to juggle their parents and their children at the same time. So there's an emotional and psychological toll of this in addition to a financial toll.
A term you'll hear physicians use is mild cognitive impairment, or MCI. The key word is mild here, but exactly what is it?
So mild is subtle but detectable cognitive changes. It means that you're having more trouble than someone your age with certain aspects of thinking that we can objectively see on tests that I would give you.
Things such as?
Short-term memory, attention, multitasking, language skills, spatial skills. So we would give you a series of tests and compare you to other people your same age. And if you're having a lot more trouble with that than what we, in comparison to other people your same age, that's important for us to know.
Yeah, and why is it important? Because we were talking about symptoms being mild
right.
at first.
So the reason why it's important is that there's a conversion rate. So between 30 to 50% of people within 5 years of an MCI diagnosis will have dementia at that point. So it dramatically increases your risk of getting dementia in the next several years. So we want to monitor that. The other issue is that you may have a treatable reason for your cognitive impairment. It may not be something catastrophic like Alzheimer's disease that we can't do anything about. So if I know that early enough, then we can intervene on that and hopefully cut those risk factors down.
Yeah, I'm jumping the gun just a little bit, but if you are like cancer, early diagnosis, hopefully better results, outcome, is that the case here with MCI leading to dementia? Can you slow that process down or even prevent it from happening?
You can. So the first thing is that many people have what's called mild vascular cognitive impairment. So their cognitive trouble is not due to a developing Alzheimer's reason or some other
Could be a
degenerative
blood flow
problem.
issue.
Yeah, blood flow issue. It could be the fact that they have, multiple things like hypertension, diabetes, high cholesterol, and that's been a burden on their brain for 30 years. And that this might be the moment where they're ready to change their diet and exercise. And many studies do show, even in your 60s and 70s, if you start changing your diet and really doing certain types of exercises, it can decrease the likelihood that you're going to get worse over time.
Where are the keys? I know I put them somewhere. I meant to put salt and pepper. I just forgot. These are the normal things that we all deal with, on a regular basis. But when should a family member start to worry and start to seek evaluation?
Right. So I would, when they start noticing it, it's important for them to catalog it a little bit in their mind. The first memory slippage or the first issue, all of us get memory fluctuations throughout the day. Just this morning, I could not find my 4-year-old daughter's hairbrush, and I was running around the house and could not find it. And that happens all the time to me, so that's normal for me. But if your loved one has a distinct
Daddy,
change,
here it is.
yeah, right,
Yeah.
exactly. And then I'm late. So my mom used to always say, if I have to come up there and find it, and then I would find it immediately. But if it's a change in your loved one and a distinct change, then that's when, and it's kind of been persisting for some time, for a few months, then that's when I would go to your primary care doctor and talk with them about it.
Neuropsychological exam, what's involved in it, and how does that help you determine where the memory problem's coming from?
You can always tell in the waiting room when patients are coming to see me, because everyone's usually really anxious, and the lady up front is really good at telling them that, don't worry, Dr. Sawyer is really nice, it's going to be okay.
And I can't study for your exam.
You can't.
Right?
Well, yeah, most people, I've had one person who looked up a bunch of stuff on Google, but really our job is for me to get a sense from the patient and from their caregiver what they're noticing. I always joke that my office is a container of disagreement between husband and wife, because both people have different opinions about a memory trouble. And then after that, we'll want to put them through a battery of tests, and those tests are designed to get a sense of how do they compare with other men or women their same age. And those tests take a look at things like attention. So if you're having an attention trouble but not a memory trouble, well, that helps explain why you're having memory trouble for me. Because if you're not focused, then you're not going to remember it in the first place. Or if your processing speed is slowed down considerably, that can result in memory trouble. It's similar to the Lucille Ball episode where she couldn't process all those chocolates at the same time, right? It's just going to
No one could process
that
the amount of chocolates that she was asked to process.
Right. And then after that exam, my job is to take a look at someone's medical history, their clinical exam, and then all the test data, and get a sense of what's going on with someone's thinking and what can we do about it.
Is it possible, in fact it's likely, that one of the spouses is correct, the other one is incorrect, but just doesn't remember that he or she is not remembering?
Absolutely. I always try to say, the truth's in the middle, and that way people can be at ease when they're upset with their spouse about telling me at least, about how they're not paying bills or they're losing their way when driving and things like that. The other piece is that the proof is in the pudding. We're going to do these tests, and if there are problems, they're going to show up. And so that's really where I'm able to help the family understand what's going on beyond just their subjective sense of things.
Some of these memory issues could be things like insomnia, sleep deprivation, but there are other areas that are more serious that may not be treatable, right, and reversible.
Correct. So the main reason why people are anxious really in the waiting room is they are afraid that this is something like Alzheimer's disease or related to Alzheimer's disease. And that's an understandable fear, and that's something that, I'm always chastened by the fact that, my job sometimes is the worst day in someone's life, right? In terms of talking to them about what's going on with their loved ones thinking and what they think about the trajectory of the next several years or more are going to be. And so that's why we take the evaluation and diagnosis really seriously, and we want to find other reasons for memory trouble beyond something that we can't fix. And that's the aim of the clinic, really.
Our guest this week is neuropsychologist John Sawyer, and we're talking about memory trouble. How does dementia fit in with Alzheimer's disease? How are they related? How are they not?
Yeah, so dementia is just a broad classification. As on the screen, hopefully you see this kind of umbrella, and we think of it like an umbrella term. Dementia means that you have cognitive impairment and you have trouble functioning in aspects of your life, like paying bills or remembering to take your medications. And you have trouble with those functional skills because of the cognitive impairment, not because of some physical issue or something like that.
Why are we seeing more cases? Are we seeing more cases of Alzheimer's disease? And if so, why do you think that is the case?
I think
or do we know?
Yeah, so most of what we're really seeing in the research now is that when you have a population that's getting older, but our population also has a lot more vascular problems like heart disease, high cholesterol, type 2 diabetes, the brain's ability to compensate for that decreases when your brain is more vulnerable. So that's probably why we're seeing more of it.
You've talked about how you're putting patients at ease, or trying to. We have a patient testimonial that the doctor has brought along, prepared by the Ochsner production team. So let's take a look.
My name's Catherine, and I have a loved one in my family very near and dear to my heart that a few years ago started having problems with gait and memory. Bills were not getting paid. Things that normally this person would take care of weren't getting taken care of. I know that Ochsner is known for its neurology program, and we went for neuropsychological testing, a good objective professional opinion to let us know what was going on and make sure that we weren't interpreting something the wrong way. And so we were linked with Dr. John Sawyer, and he did some testing with my loved one. Turned out my loved one was diagnosed with dementia due to Parkinson's plus. Not only did we get results, we also got recommendations about what to do about it, what to plan for, legally, long-term care, how to help my loved one with any behaviors we might see, how to plan for safety in the home, how to keep them engaged and healthy and mind and body as possible. It was just so helpful to know that there's all this information out there and all this support out there, and getting it right in one place at Ochsner for Dr. Sawyer was just so comforting. It's not without difficulty, but with the support and resources that we know that are out there, it's helped us provide safety for my loved one, and it's also helped us provide time and quality of visits.
We thank her for sharing her story. So how much of your role as therapist when you're breaking news to patients and their families?
Absolutely. I think a lot of my role is to be therapist in those encounters. And to also get a sense of people's nonverbal or unspoken feelings, and being able to give them a space and to be a container for them to express that. A lot of my early training as a psychologist doing therapy has really helped to prepare me for these conversations.
So eventually patients are going to end up with you, but there's a self-assessment you wanted to talk about, and how does that work?
Right. So one of the things that I think patients can do if they're really worried about memory trouble, or if you're worried about memory trouble in someone else, let's get a sense of what type of symptoms are going on. So is it short-term memory? Is it mainly attention trouble? Is it that you feel like you're making just bad decisions? What are the symptoms? How common is it? So do you notice that it's all the time, or is it just sometime? We know that related to a neurodegenerative reason, you're not going to have necessarily periods where everything's back to normal again for a long period of time. So it's important to know how frequent it is. When did it start? Did it start all of a sudden? That's not like Alzheimer's disease, for instance. Alzheimer's is a gradual, kind of sneaks up on you type condition. Or did it start slowly? And when it started, have we noticed that it's gotten worse over time, or has it stayed the same? Is it up and down? These are all things that I think people should pay attention to. And then also, what's going on in their daily functioning? Frequently, people may have some trouble, but they're driving fine, they're working fine, they're paying their bills fine. That helps to communicate some severity around it and rushness about getting something assessed. If the family's in denial about it, and then 2 years later we're having driving trouble and we're not paying bills, then it definitely increases the urgency of getting an assessment done.
How is dementia diagnosed at Ochsner, and does dementia tend to run in families?
So at Ochsner, dementia is diagnosed. The main way is that a patient will come into primary care, and either the patient or a loved one will report some cognitive trouble. They'll get sent to neurology and to neuropsychology. And our memory clinic will evaluate these patients. We have, like myself, a neuropsychologist and a neurology nurse practitioner or a neurologist. The goal is to take a look at what are all the factors, whether it's labs, imaging, physical exam, psychological stressors in the person's life, what's going on in a holistic way that may be causing their memory trouble. Can we address those? And we also want to review the neuropsychological test data. Is the cognitive profile on testing similar to someone with Alzheimer's disease? Does that make really good sense? Or when I look at it, the profile does not look like something related to Alzheimer's disease, so it has to be something else. And so the point really is we want to look at multiple data points, not just one. And then at that point, we talk to the family. Sometimes we're really certain about what's going on. Other times we're not. We want to follow these people over time. It is really hard to hold two things in your mind. It could be this really difficult, devastating thing, or it may not. And so we have to reassess things in 6 to 12 months.
Not as clear, certainly, as diagnosing cancer or heart disease.
Right.
Yeah. And does it run in families?
Oh, so
Tend to run in families.
The earlier dementia is diagnosed, typically the more it runs in families. So if someone in your family gets Alzheimer's disease in their 50s or early 60s, then it is more genetically linked. The later that it manifests, certainly it increases your risk factor, but it isn't something that I as a 50-year-old would worry about if my grandmother at 82 was diagnosed with dementia, because there are many reasons why that could be the case. Now, if many in my family in their 50s develop dementia, that would make me a lot more concerned. And there are certain like familial types that we would want to assess for.
If you've confirmed a patient has dementia, what happens next?
So what we wanted, so that's a really good point. A lot of evaluations just stop there and then tell the families, all right, good luck, see you later. And that's not what we want to do. What we want to do is to be a space where families know they can get their care. And so what we've done is really enhanced our care management program for patients with dementia. And if you have high risk or high needs, we've recently got a gift from a philanthropic foundation to help our families that are going to the hospital a lot because of poor management of dementia symptoms. And so people can, if they qualify, they can get access to that program where they have telehealth visits. So like Skyping essentially with a provider once a month or as needed throughout the week. We also do consultations in nursing homes to help them optimize functioning for patients as well. So we don't just want to be a place where you get diagnosed and then see you later. We want you to feel like your home is there in terms of your dementia care and what can we do to really help the caregiver and the patient function.
Well, diet can play a role in dementia prevention, as we find out in this week's Eat Fit Minute with Molly Kimball.
So if you're not already incorporating blueberries into your diet on a regular basis, here are a bunch of reasons to start. For starters, they are low in calories, low in sugar, high in fiber. Ounce for ounce, blueberries have about 1/3 the calories of regular fruits like bananas, with about 20% less sugar. They're also really rich in fiber, and they're loaded with water, which makes them hydrating as well. And the antioxidants in blueberries are not only good for our heart health, they're good for our brain health as well, helping to boost our memory, our cognition, and our thinking skills. So when it comes to fresh or frozen, which is best, the answer is both. Fresh is great, but frozen, especially when they're frozen right at that point of harvest, they're often just as nutritious as fresh, if not even a notch more. So just be sure to check the labels closely, be sure there's no added sugar, and a cost-saving tip is you can buy up fresh blueberries when they're in season but the price is low and freeze them for use later. So you can blend them into smoothies, add them to Greek yogurt, put them in cottage cheese, or just have them fresh straight out of the bag. So we're not saying that blueberries are going to solve all of our cognition problems or make us that much smarter, but every little bit helps. And before making any significant changes to your diet, of course, always check with your healthcare provider and a registered dietitian.
And rinse your blueberries. That's the Tom Bagwell, the 10-second tip before you eat them. Love blueberries. So we have about a minute left. Tell us what you want our viewers to know about dementia, dementia prevention, dementia evaluation, dementia treatment.
So as far as dementia evaluation, I think it's really important for people to get a good quality assessment. That way we know what's causing it, because until we know what's causing it, there may be many things we can do about it. As far as dementia treatment, continue to invest in healthcare organizations and research centers that are advancing our understanding of dementia research.
Like yours at Ochsner.
Right, like ours at Ochsner. And then finally, prevention is about consistently engaging in the healthy behaviors for our heart every single day, year in and year out.
There are things we can do. Dr. Sawyer, thank you so much.
Sure.
All right. I want to thank Dr. John Sawyer for the education he's provided and for his work at the Ochsner Health Center, talking about cognitive disorders. Well, to make an appointment with any of Ochsner's physicians, including this week's guest, or to register for any of Ochsner's Hello Health seminars, you can call Ochsner at the number you see on your screen. It's just for viewers of this program, or you can send us an email. We'd love to hear from you. There's our address, hellohealth@ochsner.org. As a reminder, you can re-watch this week's presentation or many of our other Hello Health programs. The way to do it is to go to the Ochsner website and type in Hello Health in the search box. That'll get you going. Our thanks again to this week's guest. Thanks to Humana and Ochsner for making our program possible. And our final thanks, as always, is to you for your support of our program, Hello Health. I'm Tom Bagwell, and we'll see you next time.